Morning, everyone. We just have a few more still joining us, so we're just going to give it about a minute and then we'll get started into our webinar today. So you're all very welcome. So we still have a few more joining us. We seem to have calmed down a bit in the numbers there, so we'll just get started, Debs. Is that okay? Delighted to welcome you here to our first free webinar in our monthly series. So this is the first free webinar of our monthly series. So hosted by myself, Alison from A1 Risk Solutions, and Deborah Harrison. So Deborah will be leading the clinical side of today's presentations. She is our clinical director and the founder of A1 Risk Solutions. Today's free webinar is on mobility assessment, tackling common concerns and practical tools to guide you. So this webinar is being recorded. So if anyone misses it or has any difficulties during it, don't worry, you can catch up with the recording of it. If you have any questions, if you can pop them in the chat box. So we have a first question in there: will the PowerPoint resource be sent out following? So you won't get the PowerPoint, but you will get the full recording. And we also have a complimentary blog today, and so 10 frequently asked questions. So that will also that's now available on the website. And also the tool that Deborah is going to mention is also on our website. So we'll send a link to that in the post-webinar email. And we'll cover all questions at the end. So if you have any questions, just pop them in the chat or the Q&A box, and you'll hear it then. Just the first one there is someone can't hear anything. If you just want to check your sound settings in the corner of your screen, and if you're connected to a couple of screens, sometimes just switching between screens. And if that doesn't fix it, don't worry, the whole thing is being recorded, as we mentioned. So I'm going to pass over to Deborah. Just Deborah, I can't see your screen. It's coming up, but there's no PowerPoint there.
Oh, I don't know. Stop sharing. Just a minute. Right, everybody's. I'll have to leave and rejoin, I think. I don't know what's going on here. Sorry. Hang on. Just give me a sec. All I can see is loads of boxes with loads of names on.
Yeah, so if you just hit the share button again.
I just did that and it just didn't do it. Don't know what on earth is going on. Hang on. Let's have another go.
There we go.
Has it come on?
Yeah, that's it now. I think it was there. It just had frozen or something. Yeah. So perfect. Okay. I'll just turn my mic off and camera and off you go.
Okay, well, welcome and thank you very much, Alison, for an absolute wonderful introduction. And we've got plenty to share with you today and over the coming month as well. And I'll just get straight in there. So I will just take us through the presentation. Okay, so the aims of the session is to explore the mobility assessment tool. Some of you will be familiar with this and some of you may not be familiar with this. And what we did is we was doing a piece of work with Sussex NHS and with several of you across the country and exploring what tools would actually work. And we've done all this research around the use of this tool and we wanted to share this, and we thought what a better way to share this would be via a webinar, so then you guys can then share it with your teams, and it'll help people actually understand about the mobility assessment tool and get the message out there for people, because at the end of the day, if we can all work in a more standardized way of working, it's absolutely 100% better for the service users and patients. So I'll just briefly tell you why we did this. Back in 2017, myself and Joe Webb did a colossal piece of research exploring the mobility assessment tool, and we was exploring, prior to the mobility assessment tool, I should say, was exploring what were the barriers to the implementation of proportionate care. So within the barriers, because you can't ever kind of take things forward unless you've given people solutions to what their barriers were, was the whole thing of okay, we haven't got the tools to do this. So we was given a long list of tools that people wanted, their wish list, and myself and Joe Webb, who worked at the University of Salford at the time, actually, set ourselves our own personal goals, which was, okay, we wanted to upskill clinicians across the country. So, yeah, that's where this MAT tool actually came from. So we identified that gap with proportionate care. So there was lots of concerns out there. So, lots of unmet need, and, that whole thing of giving assessors the confidence to prescribe the correct equipment was one of them. And assessors actually identified within the research that we did, and the research, it was actually done with 4,576 clinicians and prescribers of equipment. So we had a good basis to work from, and they identified that they lacked in the skills when assessing for that individual with a variable ability specifically. And, the results were, if they were lacking in that confidence to prescribe for people with variable ability, they was going to prescribe for the worst case scenario. So yeah, it was just, yeah, it was something that was needed, because the last thing we actually need in for any of our service users is we don't want, okay, they're that variable, so 1 minute they're walking, the next minute they actually need a full body hoist or they need a stand aid. And it was like, okay, how do we actually assess for that? How do we keep the caregivers safe? How do we keep the service users safe throughout this? So I'm just going to talk you through the health professionals' concerns. The health professionals, they were concerned that the patient will be at risk if we send them home with one carer instead of two. When we're talking about hospital discharge, there was concern that they didn't have access to the equipment. So I can't send my client home with a single-handed care package, so to speak. I'm going to have to complete lengthy, complex risk assessments when I already have a huge waiting list. Sorry, I nearly lost my teeth then. Nearly started speaking Russian. So what about that client with variable ability? Can we actually prescribe proportionate single-handed care for those clients? So those were the concerns that actually came out of that research in 2017. So the ask was, we wanted to maintain and improve an individual's mobility, as well as, document and prevent deconditioning and those associated issues. We've got moving and handling assessors, I should say, who felt guidance and tools were lacking, and they wanted to facilitate that whole robust Care Act compliant assessment. A tool that identified which pieces of equipment was most suitable to prescribe or use. So, it wasn't just a tool that was being developed for the prescriber, it was a tool that was going to be used for the people on the front line, so the caregivers. A tool that was there to assist assessors justify the provision of more than just one piece of equipment, because we all know, we're all out there. You've got we've got loan stores who are kind of going, okay, looking after the budget, because the budget is very precious. We don't want to run out of our budgets, but if we can keep somebody mobile and we can justify why we're keeping somebody mobile, and we've got a tool that'll help us do that, it'll help the loan stores understand when we're asking for that. We don't want everybody going into a hoist and sling all the time when it's definitely not required. And we needed a tool that would work across the whole system with all stakeholders, with clinicians, from carers to those in the community, from those in the acute setting, those in the intermediate care setting. So myself and Joe Webb went in 2015, and that seems forever ago now. we went over to America and we saw this being delivered, and it was being delivered, and it was called the BMAT tool. And we had a conversation with the people that were out there, and it was like, okay, I like your tool, I like the principle of the tool, but actually it won't work in the UK as you've got it currently, and we asked for permission. Could we work on the tool and look to see if we can, make it so it was usable across both your queue and all them different settings. And what we also was asked as well when we did some work with Dudley Council back in 2017 is, could this be used as an audit tool as well? So from visualizing that first initial tool, the ask was actually quite large. Yeah. So it didn't just become all them things, it became so much more, which I'll describe to you at the end. So what we came across in Dudley Council, when we was doing some work for Dudley Council, and what they described, that they had inflexible historical blanket plans of care, and it was like, okay, well, they didn't even have at the time, they had, okay, you can basically use a piece of equipment which was like, say, a rotor stand, or you was hoisted. And it was like, okay, because of the whole thing about prescription of care, and there was no real kind of anything set in stone, no real tool out there. So we did some work with Dudley Council, and what Dudley Council also wanted at the same time was they wanted us to create a training package around reablement. Okay, because what they wanted to do was they wanted us to work with their care providers and turn them into reablement workers. Well, if anybody knows me and the training that we deliver at A1 Risk Solutions, okay, that was a nice little challenge. And yeah, I was so looking forward to it. So yeah, and we kind of said, okay, we want to get these people on board with prescribing care proportionately. But actually, to do that, we need to get them to help us um, develop the tools. So it was the care providers who were going to be the reablement workers that helped us develop this initial tool and the front page that was so lacking. That didn't work in the community. But yeah, so thank you to Dudley Council and to Christine Outhwaite for all the work that we did together. So I just want to talk you through a very brief study, and I think you've all obviously come across these case studies in your own work, and I'm very fortunate in my job role. I'm very blessed. I get to speak to great people like you, but I also continue with my clinical work as well. So, there's been case studies going out there. There's been lots of considerations, from case law that has happened. So, one case in particular, there was no consideration for actual individual needs. There was no consideration of the risks to the gentleman. There's no assessment of those risks, and there was no consideration for the suitability of other equipment as opposed to using hoists. And that case study itself actually lends itself to actually this tool, because we need to be flexible with the way that we work with people. We need to kind of give people the best opportunity we can give them, so that their variable ability and they can achieve the best that they want to achieve in life. As a therapist, many of you are therapists out there, you'll be very, very familiar with, getting the most out of the situation for that individual so they can actually achieve their goals in life. And that's what it's all about. So I'm just going to take you briefly through the research process. And, I've already said about 2016, and the original research did come from Boynton in 2015, and we did that survey, and it was 4,586 people, and we generated them themes. And this was one of the themes: we need tools. That piece of survey was published in the column in 2017, and then in 2017 we worked on a first draft with Christine from Dudley Council, and that first draft, that first focus group, was 12 people. Okay, and that version 1 of the tool was piloted and adopted by Dudley Council and Sefton Council. So initially it was 55 people, but it grew, and it grew exponentially. So the more we actually piloted it, and we used that whole Delphi approach, and we kind of had focus groups, then more focus groups, and we just adapted it as the research process took place. So those of you out there who are not kind of familiar with research processes, and kind of think, okay, it's nearly 9 years since you started this. The tool has been out there for quite a while now, but it does take a while to get published. I've got to tell you that. So then what we had is we had feedback between 2019 and 21. We gained feedback from, it says over 1,000 people, and the over 1,000 people were feedback from assessors who were skilled in proportionate care. And how do we know that these assessors were skilled in proportionate care? It was because 2019 to 2021, all these people were exposed to the tool, and we gained feedback from them. And when it says over 1,000, it was well and truly over 1,000. It was thousands. So from that feedback, version 2 was developed. Then in 2021, we identified a pilot site. The pilot site was with Sophie and Annette from Forth Valley, and we had access then to over 200 clinicians and assessors, project managers, transformation directors, and we had access to these people, and they became our second consensus expert witness group, and version 3 was developed in 2022. And version 3 in 2022 was being piloted across 12 organisations, and we got it published. Okay, so I'm just going to talk you through the tool, and you'll see the tool very briefly shortly. And like Alison said, each of you will get a copy of this tool. If you've got any questions, just drop me an email or a message, and that's absolutely fine. And yeah, Norma, our clinical lead from A1 Risk Solutions, she's written a fabulous blog, and yeah, please read the fabulous blog. Yeah, it gives you, it's there in paper, for you to read. So the page, the front page, was the recording sheet, and that's what we developed with Dudley Council. And yeah, it was great to actually work it and rework it with them people that were actually going to use it. And because we did that as part of the training, it gave them ownership, and they really bought into the tool. So, it is that tool that's available and suitable for a range of assessors, including assessors, care providers, and informal carers to actually use. And what we found with Dudley Council was, especially over COVID with Sefton Council, it was used predominantly to do hospital discharges, to do lots and lots of assessments in COVID virtually. And it records a very, very simple assessment of the individual's mobility at that moment in time. And it, like it says there, it can be assessed by the assessor remotely or face to face. Remotely, I say that because, we've got the evidence out there that it was used a lot in COVID. We had all them dreadful restrictions that took place then. It determines also what type of equipment for the assessor to prescribe. And yeah, so it can be used for that person with variable ability as well as generally. And, we've got that brand new OT who's just qualified, who may not be very, very skilled at moving and handling, and who may lack the confidence. So the tool will give them that confidence. And even within the tool, there's still slight variances, and it is one of many tools that can assist you to come to your decision-making process. We've used the tool as an audit tool, and the tool being used as an audit tool is absolutely phenomenal. And what we found when we did that at Dudley Council was it gave them lots of data. It gave them so much data where they could track and measure. We've got people coming in to the service on mobility level 2 enablement and actually leave on mobility level 3 or 4. So we're not very good at recording how well we've done. We're really, really not very good at that. So yeah, it actually gave them that actual ability to do that audit, as well as it gave your patient or your service user a bit of feedback. Anybody who used to watch that driving program where they had Stig the racer and people were racing him, we turn it with the service users and with the patients into a bit of internal competition for them. Okay, well, you scored mobility level 2 yesterday. Let's see if we can get mobility level 3 off the ground and see if you can achieve a little bit more. The feedback from the staff who were using it on the front line, not the prescribers, the caregivers, was actually phenomenal. The feedback from them was, we feel part of the care process. We can easily now report back to the OT if there's a variance, if we need a different piece of equipment, instead of the care provider having to spend hours. So the process became actually really efficient and very, very lean. And that whole thing of, okay, the assessment is, carried out on a minute-to-minute basis by the caregiver. The caregiver could take a photograph of the front page, send it to the OT. The OT could look and kind of go, okay. And what we set up was, okay, yeah, I can see that from that tool. Actually, they now need a different piece of equipment. I'll order the piece of equipment. And what they did, especially in Dudley Council, is the equipment wasn't allowed to be used until they got there. They went out the day of the piece of equipment being delivered, so they could then kind of follow it up. So it actually reduced the amount of visits that were actually required by the assessor as well. So it saved a lot of time and effort on everybody's part. So here's the tool, and this is the tool completed or semi-completed. I'll just talk you through the tool. So what we've got here is we have got name, address, date of birth, them demographics there, and then across the top you've got days of the week, so day 1 to day 31. You've got the different mobility levels. So mobility level 1 is that is when they need a full body hoist, and that can be a gantry or it can be a mobile hoist. Mobility level 2 is where the individual actually needs a standing hoist or a stand aid, whatever you want to call it. And mobility level 3 is where the person is suitable to use a non-mechanical stand aid, so such as your return, your Moliff razor, your Sarah Steady, or any other pieces of equipment that you've got there that fit into that category. Now, mobility level 3, that category there's lots of variance in that category, so you need to be really familiar with those pieces of equipment, because even within that category, one piece of equipment may be more suitable than another. And then you've got mobility level 4. Mobility level 4 is where the person can mobilize and can take, it could be that they can mobilize freely, or they're using a walking frame or a walking stick. So they're classed as independent. And what we can see here is we can see this was a lady that I actually saw. And we decided at first of all that we was going to do initials in the boxes. So you may be wondering about the colours. And then we went for ticks. And then we actually decided because it wasn't very visual, and the ticks and the signatures, because it was that whole improvement process as we developed the tool. Bingo dabbers were the best. So yes, and you can see here the majority of the time it was completed. However, on day 4 at the night time, is it day 4? There's one of the days it wasn't actually, the full assessment wasn't completed. Anyway, it is what it is. You can't account for human error. So we can see here, on day 1 and day 2, the person, the individual, first thing in the morning was actually requiring very minimal assistance. And in real life, this person was furniture walking. Still on day 1, but at lunchtime and tea time, they actually needed, they needed a little bit more assistance, and they needed the use of a stand aid. And by the evening, they actually needed a full body hoist. So you see there, as we progressed to day 4 and day 5, they were becoming more and more reliant on the equipment. And that was a gradual deterioration. And the person had such a variance that the individual went up and down, up and down, up and down. But it gave the assessor, which was myself at the time, it gave the assessor the ability to look and kind of go, oh, right, okay, yes, she's having a down period. Has she got a UTI? Is it other contributing factors apart from a general variance? So it was the care providers that were completing this level of assessment and then doing a photograph of this front page and sending it through to us as soon as it was completed. And this then gives the OT or the organisation the ability then to order equipment, decide if the equipment's still working, and then decide the way forward. So what I am going to do now is I'm going to take you through the actual assessment process. And this is the gang at Forth Valley. I did say to them, I'm going to make you very famous. And he's like, okay, we'll be on your pictures. And here we go. And this is mobility level 1. And mobility level 1, and it's in brief here, but in the actual tool, you will get all the references to the tool, but you'll get the full description of what's actually required. But for today's presentation, I was just taking you through this part here, is where you do a long distance handshake. And what we're looking for here is, can the person reach outside the base of support? So we'll do it on both sides. If they've only got one arm, we may get them to do a shoulder twist and nod towards the opposite side. And can they self-correct? Because a lot of people can reach over, but they can't self-correct. Then we wanted to look as well, could the person maintain a seated position with the back away from the back of the chair? If they was able to do that, we moved to the next level. If they wasn't able to do that, it was actually, okay, they need a full hoist and, full body sling for transfers or bed rest. Okay. So the next thing that we looked at was assessment level 2. And this was quite key. And like all the elements of it are. So can they do a straight leg raise? Now, I'm often asked this, and obviously this is down to risk assessment, because we have got people whose knees are flexed even when they stand. So they may not be able to do the complete straight leg raise. And, looking at that, you may have somebody who's living with dementia. So you may kind of think, okay, this assessment process, how am I going to explain to that person? So what I carry around in my van when I'm doing my assessments, I have a football, and that straight leg raise, actually, I say kick the ball, and they kick the ball. It's just something about a football and kicking. So if you're concerned, and within the tool, it does describe, some suggestions of, the handshake is quite a good one, because that's something that's ingrained. If you've got somebody with a learning disability, you may want to do high five, or you may have a buzzer that they like pressing. So there's lots of different ways and techniques that you can use with your client group. the person to push up from the side of the chair. Now, if that individual has got dementia, and you're just asking them at this point to lift the buttocks from the back of the up off the chair, they may not understand that complex description. However, you may show them a coat and say, would you like to come? And they just get to that point, but you've actually carried out that. The next thing is actually holding on. So I know there is an equipment supplier out there who says you don't need to hold on to our standing hoist. But if we all just think about this, if you don't hold on to something and you relax your shoulder girdle. So I'd like everybody to do that now. Just relax your shoulders and sit down with your hands on your lap. Okay, your shoulder girdle is very narrow now and relaxed. Now, what I'd like you to do is hold your hands out like so, like you're holding on to a standing hoist. Your shoulder girdle has now broadened. Okay, so literally, I have tried it. I've tried both techniques of using standing hoist, and literally, if I've got a broader shoulder girdle, the sling is less likely to come up and over my head. So that is something that I'm looking at. Can they hold on? Okay, so those were the three things that they need to. If they can't do these, okay, you may want to do a more in-depth assessment before you make the decision of full hoist, so such as a straight leg raise, or if they are able to do it, okay, we're going to move to assessment level 3 now. So this is where we're assessing, are they suitable to use a non-mechanical stand aid? Okay, so what we're looking for here is we're looking at two components. The first component we're looking at is for care handling. Okay, so can that person stand up for a minute? Because what I'm looking for is that person to stand up. When they've stood up, I'm going to transfer them onto the commode or shower chair. I'm going to then remove their trousers. I'm going to then remove their underwear. And then going to take a pad out. There may be a bit of excrement on the pad. I may have to give them a wipe before I sit them down on the commode or shower chair because I don't want everything all messy. So we did a bit of a time and motion and we looked at that. So it was anything between 45 seconds and at least a minute to actually achieve that for care handling. How you get the person into standing, I'll let you judge on that. But, you know, can they maintain that stand? Because we've got people who use razor recliner chairs who can stand for a minute. But with the original tool, they had to stand independently. So what we're giving you the option of actually, okay, you know, you may use a razor recliner chair to actually stand that person up. If they're not able to do the stand, for care handling, you may defunct then to using the mini lift. So let's just look at how we could use this differently. So in your rehabilitation model or your reablement model, and I wouldn't use this as a term, I never use it as a term when I'm working with care providers, and I will say, okay, I want you to do some standing practice. So when I'm using this piece of equipment, whichever piece of equipment it is, I will say it's okay them to stand up for a couple of seconds. Okay, so if the person, the individual, from a therapeutic perspective, so when we're doing standing practice with the care providers are doing standing practice, in between the therapist actually going once a week. Okay, so that is, again, it's about rehabilitation, it's about reablement, getting the person's mobility to progress. So from a therapeutic perspective, we want to know, can they stand up for a couple of seconds? Okay. Or even if they could stand up for a second and sit straight back down, they've actually done that full stand using that piece of equipment. But then for care handling, they're going to use the mini lift or a standing hoist. So I have got a gentleman that I see, and basically for standing practice, he uses his stand aid and non-mechanical stand aid, and then for care transfers he uses his standing hoist. I hope I've explained that well enough. So we're just going to proceed to the next level now. Okay, so this is so from my accent you'll probably guess I'm from the edge of South Yorkshire, and we've got a lot of brass band music going on up here at the moment. So those of you who are old enough to know this will remember the film Brassed Off. And yeah, I like to do this with the clients that I see. So play a bit of brass band music to them. So what we want the individual to do is we want them to do it with or without a walking aid, depends on their ability. Okay. You may give them a walking aid because they may be a little bit unsteady, but can they step forward and step back, and can they march on the spot? Obviously, they're not going to step forward as quickly or march as quickly as what you would, but it's, you're looking at, can they use a walking aid here? If they're not able to do that, okay, we're looking at, using that non-mechanical stand aid again. So here what we've got is this part of the tool was developed for the carers, so for your non-healthcare professionals, and what we found is healthcare professionals use it as well. So it gives us that ability to mobility level 1, they're unable to do this, that, and the other. Mobility level 2, they should be able to do this, that, this, that. Mobility level 3, and the pictures that are in there, obviously they can be swapped out for pictures for the type of equipment that you're using. And this was the reason we've got the pictures in there is because this was the equipment that Forth Valley was actually using as part of their proportionate care rollout. So these are the results of what we found. We found it was really, really lent itself not just for doing reablement work, but for prescribing proportionate care. We found that during the assessment side of everything, it actually really assisted with the variable ability. We actually found that the care worker, instead of having somebody write, oh, the person needs to be able to do this and the person needs to be able to do that, the care worker knew what piece of equipment that they needed to use on that time and on that day. And it actually gave them a bit of job satisfaction. And that's what they fed back to us. They actually felt part of, I mean, we used to have some care workers who'd say, I'm nearly a therapist. So, well, if you get your qualifications and go to university, it is something, it's given me an insight. So it gave them a lot of job satisfaction. And then the prescribing staff, such as the therapists and the moving and handling prescribers, it gave them consistency and a tool to use. And, we're always going to get somebody who falls outside the remit of this tool because it is one of many tools that you can use. The service users or the patients, their mobility levels are maximised to the maximum on that day at that time. And it meant in the morning, if the mobility was good, they may have stood, they may have transferred. And like the lady that I was working with, she was able to mobilise freely with her furniture. And then in the evening, when she was very tired, or the days when she was very tired, it meant she was able to then actually be hoisted. And her husband was absolutely thrilled because her husband said, well, it gives me that ability to know exactly which piece of equipment to use. And it actually gave her some encouragement. And her husband used to stand there with a sheet to say, look how well you've been doing. So they really like the bingo dabbers. Organisationally, it gives you a more standardised way of working, and it was definitely more efficient. And what Dudley Council actually felt was that it gave them this ability to actually cut down on one of the visits because there was just going out then to actually assess the person with the equipment. Instead of going out to see the patient, do the assessment, then do another visit later on with the equipment in place. And for the system, when I talk about the system, I mean across health, social services, across intermediate care. So we've got whole systems that use this as a tool. So we've got Sussex, they're looking to use it across their whole system. We've got Hampshire, we've got ICB with Southampton. They're using it across their whole system, and other systems are also using it across their system as well, such as Forth Valley. So it's not just used in silo. So if we use things in silo, it means none of us are speaking the same language, and it makes the whole discharge process out of hospital so much slicker, and we're understanding what people are talking about. So I'm going to take questions in a minute. However, before that, I just want to, and it was quite funny before, 2 minutes before we came live, me and Alison added this slide. Yeah, we've got up and coming webinars. On the 1st of July, I'm speaking with Care England and ROSPA qualifications. And what we're doing there is we're speaking about how proportionate care can be used across the care sector in care homes predominantly, and the work that we've done there. And it promises to be, we're looking at the level 2 qualification and what that means to care providers. So feel free to actually share that with your care providers that you work with, because it'll give them a very good insight into, okay, what is achievable. On the 15th of July, we've got our lovely Norma Finlay, and she's looking at safe transition and moving and handling risk assessments for mobile shower chairs and commodes. And then again at 11 o'clock, I'm doing another webinar, or 2 webinars. On the 17th and 25th of July we're doing a proportionate care webinar, and it's looking at how it was implemented across a whole system. And we're still working with these, the University of Hospital in Southampton. So that's at 11 o'clock on the 17th and 25th of July. So you'll be sent that information, and yeah, any questions, and I'm quite sure, please put them in the chat and we can talk through the questions and answers now. But that's, yeah, contact us. I'll just stop sharing now.
So we have our first question from Georgia. Just interested in your thoughts around where would transfer boards be within the levels. So just interested in your thoughts around where would transfer boards be within the levels of the mobility assessment tool?
Well, if we look at, and we've got to think about this, I mean, this wasn't something that we specifically looked at, but it's kind of like looking at what their ability is. So I think the ability to, they've definitely got to be able to sit upright. So they've got to pass mobility level 1, and they've got to have some upper shoulder, and they've got to have some core stability. So that whole thing of push up, and, so I think if they was able to pass level 1 and able to achieve level 2, and it isn't something that I've looked about, and you put me on the spot, but that is absolutely great, fine and dandy. So yeah, I'm thinking maybe level 2. Yeah. Thumbs up if everybody agrees with that. If no thumbs up. But yeah, thinking about that, yeah, maybe.
And if Georgia, if that hasn't, if you feel like that hasn't answered your question, just shoot us an email to admin@A1 Risk Solutions, and we can put you in touch with Deborah directly. So next question is from, I hope I'm saying this right, Formosa Ramona. So how is assessment level 1 completed when the person is unable to get into the chair pending your assessment? And someone's just commented back, on the side of the bed, perhaps, question mark.
Yeah, so I know with the original tool, they used to do it on the side of the bed. However, personally, you may call me risk averse, but I like to take positive risks. So I would hoist them out into the chair. Does that make sense? Because if you've got somebody who's not able to maintain the sitting balance, if you're sitting them on the side of the bed, so that was one of the things that when I saw the tool originally from 2015, I was like, yeah, sit on the side of the bed, you're very wibbly wobbly. Is that a term, wibbly wobbly? But you've got the potential for the person to fall side to side, whereas they've got the lateral supports of the chair, and you've done the hoist out transfer. So that's what I would want to do ideally, especially if we've got some real concerns about that. If I know that they are going to be absolutely okay, and they're able to sit up on the side of the bed, and I probably would do it. But if I've got some real concerns because they've been on bed rest, they've deconditioned, and I know that's going to be an issue, I definitely wouldn't sit them up on the side of the bed. Hope that's answered your question.
And then the same person again, does the measure take into consideration personal risk factors or environmental risk factors? Does that make
No,
sense?
yes. It's like I said, it's one part of a tool. So another tool that myself and Joe Webb developed was a whole risk assessment of looking at, and we've incorporated this within that tool. So this is just looking at their mobility. So this is just part of your whole risk assessment process. No one tool tends to put everything in it. So, it's kind of like you wouldn't have cognition in here, like you wouldn't have environmental in here as well. This is just looking at their mobility levels.
Yeah, okay, thank you. And then, so some people have asked, yes, we will, in the post-event email, we'll include all the webinars Deborah mentioned there and the links to join them. There was one more, it might have been in the Q&A from Stav. I think Stav has just completed one of our courses actually. Do you have any instances of this being used in a hospital setting, being integrated into daily checks and completed by healthcare assistants, or any tips in rolling this out?
Stav, it's in hospitals out there at the moment. It has been for quite a few years. So Southampton, the webinar that we're doing with the lovely Hannah Foxley, they're using it in Sussex. So the webinar that I did the other week with Fiona, they're using it there, and they're using it in Forth Valley. So it is being used. It has been being used quite extensively in hospitals since about 2022. So a good 5 years. Yeah.
That's okay. And then I think there's one more question. There's quite a few questions. So just to reiterate, we will send in the post-event email the link to the recording and the link to download the MAT tool. And then we also have a supplementary tool and some frequently asked questions. And there's quite a few in there. Stav says thank you. One more question. So this is the last question. So just to confirm, when you talk about number of visits being reduced, would we order equipment to the person's house prior to the visit, or are we asking the provider to use the tool prior to the OT visiting, and then the OT orders the equipment based on the provider's use of the tool? Do you want me to say that again?
Yeah, so we what we did in Dudley when we very first developed the tool was we obviously they've had a pre-assessment, they've already had an assessment, they've already got their equipment, the person's condition has changed or they've become variable, and because the care providers or the reablement team is that case were using the tool, the picture was sent via a mobile phone to the therapist or to the manager. The manager then posted it onto the therapist. The therapist looked at that, went, okay, yeah, I can see that. So actually, because the care staff were trained in it, and then the therapist then went out on the same day, either the morning or afternoon, and literally went out. So it cut out that. And then the therapist could judge then. Personally, I've used the tool extensively, doing a virtual assessment first. So it gives me a good idea what to take with me. So it can be a great tool to actually really reduce the number of visits.
Great. I think I just double check. Yeah, that's all the questions. So we're just on time there. So thank you so much. Debs, if
Thank
you
you
want
all
to check,
for
there's some
attending.
really
Hi, Susan.
lovely comments in there. So if you want to take a look at
That's
them.
nice. I will. Thank
So
you very much. Susan
so thank you
Simpson.
everyone.
Hi.
Uh,
And I noticed, by the way, just in case anybody does notice, I spelt university wrong. So sorry.
okay,
Right.
thank you everyone. We'll send the post event email out shortly. Enjoy the rest of your day. Thank you. Bye now.
Bye bye. Do you want to look if you wait till they're all out?